I'm Dr Gretel Davidson, outgoing new fellow representative on the board of the Faculty of Pain Medicine at the Australian and New Zealand College of Anaesthetists. In this interview, I'm talking with Dr Penelope Briscoe, AM. Dr Briscoe completed training in anaesthesia in 1982 and her career in pain medicine began in 1984. She was a Foundation Fellow of the Faculty of Pain Medicine. Dr Briscoe was first elected to the board of the faculty in 2000. She was chair of the examination committee from 2000 to 2008, and then in 2008 was the first woman elected dean of the faculty. Dr Briscoe's career has covered such diverse areas as invasive cancer pain management and harm minimisation from drug misuse. Thank you for being here, Penny.
Thank you for inviting me.
We're acknowledging the 25-year anniversary of the Faculty of Pain Medicine by reflecting on some of Penny's experiences with the development of the Faculty of Pain Medicine. Penny, if I can start, you graduated from medicine in 1976 and then went on to obtain some really interesting qualifications, the first being the Diploma of Obstetrics. Could you tell us what the motivation for that was?
I think in those days, people in 1976, people when they finished medicine and had done their intern year, decided that they didn't always know what they wanted to do. So a lot of people did a sort of a second general year. And one of those second general years was actually doing 6 months obstetrics and 6 months paediatrics at the Children's Hospital and the Women's Hospital. And I was lucky enough to get one of those positions. And then having done that position, you were entitled to sit for the Diploma of Obstetrics of the Royal College of Obstetricians and Gynecologists from the United Kingdom. So I sat for that qualification. At that stage, I actually was thinking about being a country GP, but by that stage was marrying an orthopaedic surgeon, and he was just starting his training, so we were going to have 4 or 5 years of training. And so at that stage, I went off and did a 6-month rotation as an anaesthetic resident because I wanted to learn how to resuscitate people, and really enjoyed that job. And during that time was actually offered a anaesthetic registrar position, and the rest is history.
Then you went on to get another qualification, which is very interesting, that of a diploma from the Australian Society of Hypnotherapy. At what stage of your career did you embark upon that, and what was the motivation for that?
Well, in fact, I didn't do that till about 10 years later. I did that when I'd actually already started doing pain medicine, and I recognised that people that were in pain medicine needed to be managed using a multimodal approach, and hypnotherapy was one of these modes that were actually useful. The doctor I was working with at that time, Bruce Rounsfell, had done it previously and he encouraged me to do it. So it was actually an 18-month course. I had to go in. I went to a couple of workshops originally, worked out I had quite a flair for it. I'm obviously very hypnotisable. People that can be hypnotised are the people that usually take it on.
In what sort of capacity have you used that diploma through your work since then?
Well, as I said previously, with pain, as you know, chronic pain, there isn't any magic cure. There's no quick answer to treat people, and they do need a number of strategies to manage their pain. And one of the things that is important for these people is stress management, relaxation, often improved sleep, some pain management, but really minimal pain management in their chronic field. But it does give patients a number of different strategies to help manage their pain, and I found that very useful. I used to do it myself for my patients, but it is quite time-consuming, and then over the years, as we got a number of different psychologists working with us in the pain clinic, they did the qualification, and so it became their role to do the hypnotherapy, but certainly I continued to refer patients to the hypnotherapy the whole way through my career.
You started working in the pain unit at Royal Adelaide Hospital in 1984, which is quite early in the days of formalised pain units. Adelaide was a place where pain management thrived in those early days. Can you tell us about the development of that unit and who were the important people involved in it?
Yes, well, I mean, Adelaide was at the forefront. We really were very lucky in Adelaide. We had a lot of people who were interested in pain. I have a letter dated 1961 written by a neurosurgeon, Donald Simpson, and he wrote to his colleagues at the Queen Elizabeth Hospital, a psychiatrist, a rehab specialist, a neurologist and an anaesthetist, and said, I propose that we have a meeting once a month to discuss some of the difficult patients that seemed to be unable to help their pain. And he talked specifically about phantom pain. He did say they wanted to exclude any patients with hypochondriasis, and so the psychiatrist was involved. So the first pain clinic was set up at the Queen Elizabeth Hospital in 1961. They went once a month to discuss 4 patients, and that went on through to the mid-70s. And it was a neurosurgeon that started at Donald Simpson. In 1972, at the Royal Adelaide Hospital, the pain clinic was formed, and that was formed by 2 individuals, Evan Hallett, who was an anaesthetist, and Izzy Polofsky, who was a psychiatrist, and he was a council member on that board from 1987 to 1993. And Izzy and Evan started the pain clinic at the Royal Adelaide Hospital in 1972, and then Bruce Rounsfeld took over as the director after Evan retired, and then I joined the unit, as you said, 10 years later. And then in 1975, Michael Cousins moved to Adelaide as the Foundation Professor of Anaesthesia and Intensive Care at Flinders Medical Centre. Flinders Medical Centre was opened in 1975, and Michael was their Foundation Professor, and he set up the pain clinic at Flinders in 1976. So we had our 3rd public pain clinic by the mid-70s. In fact, our other claim to fame is in 1990, we hosted the 6th World Congress for the International Association for the Study of Pain. I must admit it was probably Michael Cousins driving it at that stage.
Was your interest more towards the acute pain or the chronic pain?
I basically am a chronic pain specialist. I needed to do acute pain call in my early days, but that never really appealed to me as much. I really like chronic pain. I like the complexity of the patients. I like the fact that you have to try and problem solve. I recognise the fact that there was no quick cure. I recognise the fact that you needed to actually be a support person and be a champion for your patients. And so I took that role very seriously. And I must admit that, chronic pain to me meant you dealt with patients over the long term, you got to know them well. And I have to say I was very lucky when I retired. In the last 6 months of my practice, I saw a lot of my long-term patients to basically say, I'm retiring, what would you like to do? And so many of them were so grateful that over the years that I had been able to be their support person, their champion, standing up for their rights. And I think chronic pain is a great career.
Can you tell me how you went from a career in anaesthesia to a career in pain medicine?
I had my first daughter in May of 1984, and I took, I think, 2 or 3 months off, I can't remember, and was going to go back to anaesthetics at the Royal Adelaide Hospital. I was also doing private practice in anaesthetics. In those days, you had to, when you did a private list, you had to go the night before and see the patients and do their pre-meds. So if you were working 2 days a week as a mother, it meant you had to wait till your partner got home, have a shower, get dressed, drive to the hospital, and then see your pre-meds for the next day. When my daughter was a month old, Bruce Rounsville, who I mentioned before, rang me and said, have you thought about doing chronic pain? And my brain said within 2 seconds, no pre-med. So that's how I started. And I started off just doing, I think, 1 morning a week, and then in fact, when the girls were only a couple of years old, Bruce went away for about 4 months. So I picked up to about 3 days a week for a period of time. And then over the period of time, I was doing more and more pain and deciding that really and truly I needed to either do more anaesthetics or less anaesthetics because I was starting to realise I was not perhaps doing enough. And so I gave up the anaesthetics and continued with pain management and ended up doing that full time.
Anaesthesia and chronic pain I describe as 2 ends of the universe.
Yes, they are. With anaesthetics, you know that it's going to work. You give all of the big syringe, half of the little syringe, and they're asleep. Chronic pain, you can do a block that you know is a perfect block anatomically, but they get no pain relief. It does require people to have a totally different brain.
Mm. In those early years of pain medicine, there was very little formal training. I imagine you were largely self-taught. Are there people who guided you, taught you, whose experience you benefited from?
You obviously had your senior staff members who were your mentors, And I've mentioned a number of them already. Bruce Rounsville obviously was the person I worked directly with. Izzy Pawlowski was a psychiatrist, and of course we were a multidisciplinary team. Michael Cousins was at Flinders, and I had worked at Flinders, so Michael had been a mentor. And Michael, I did spend a year in America during my anaesthetic training, and I did an anaesthetic job at the University of Pennsylvania Hospital, and Michael organised that for me. We had books. I mean, obviously, Michael Cousins' book is well known by, I think, Australian anaesthetists, and John Bonika's book predated that. You learnt on the job to a large degree.
So you went into the pain unit in 1984, and pain medicine obviously was recognised as it is now in 1998. You were one of the Foundation Fellows. Can you tell us about your involvement in the creation of the faculty?
Initially there was the Working Party, and then there was the Advisory Council, and a lot of this was driven by Michael Cousins getting the Faculty of Pain Medicine up and running. So they started a number of different committee meetings, and that people were brought from around Australia and New Zealand to be involved from the 5 different specialties that eventually formed the faculty, and they were meeting, and I wasn't directly involved. I went to a number of the meetings, but I wasn't instrumental in that early phase. But then eventually the faculty was formed in 1998, and the first Foundation Fellows were inducted in 1999. As you say, I was one of those. But in 2000 we had the first election, and I was elected onto the first elected board of the faculty. By that stage I'd been final examiner for ANZCA for 10 plus years, and I'd been on the final exam committee for a lot of that time. And so Michael Cousins actually ran the very first exam, and I was his deputy, and then I took over the role as chair of the FPM examinations committee, and we structured the examination on the ANZCA final examination. So we obviously had structured vivas in acute, chronic and cancer pain. We also had actors playing the role of patients in a role play scenario, and we then also did long cases and short cases as well. You
said that there were 5 different specialties that came together. What were those 5 specialties?
So there was anaesthesia, obviously, because it's the faculty of the Australian New Zealand College of Anaesthetists. There was the surgeons, so Royal Australian College of Surgeons. There was also physicians, Royal Australian College of Physicians. There was rehab physicians and psychiatrists.
I'm just curious, how did they come under the umbrella then of the College of Anaesthetists? What made the decision for it to be the anaesthetists as opposed to one of the other colleges?
The driving force was almost certainly Michael Cousins. And he was the person that came up with this concept because of this paper he'd written with ISP, and he therefore got together like-minded people. And as I said, the Australian Pain Society is a multidisciplinary group, and so there are neurosurgeons, psychiatrists, anaesthetists, all people involved in pain medicine as part of that. So he reached out to a number of different people. Lee Atkinson is a neurosurgeon from Brisbane, and he was in fact the original president of the Australian Pain Society. So he'd been involved with pain for a long time. Milton Cohen was a rheumatologist from Sydney. He obviously had a couple of anaesthetists. He had Roger Gook from Perth and David Jones from New Zealand. He had a rehab specialist, Ben Marazecki. Pam McIntyre was the acute pain specialist that he involved. So they were the people that he originally got on the original Working Party to work together and come to the college and put together this proposal that there should be a faculty of pain medicine. And I have to say it was a phenomenal achievement in 1988. First in the world to do it, first in the world to have it recognised in such a formal way.
Can you describe to us a little about how the curriculum was developed?
There were documents. The International Association of Study of Pain in Seattle, they actually had some documents about education and education for pain specialists. I have to say Milton Cohen was involved in writing our original curriculum. I mean, we obviously, as I mentioned before, had sort of books like Michael Cousins' book and John Bonika's book At the same time, the Australian publication of Acute Pain Management Scientific Evidence had been, I think it had its second or even its third edition by that stage. It might have been the second edition by that stage. It was quite a comprehensive book. And so there was a lot of information. Because our exam process was also multidisciplinary, we were able to draw on the expertise of the people who were examiners.
I know that you have now retired from clinical practice. What's your perspective on the position of pain medicine in Australia and around the world now?
Once again, it changes depending on where you are. I have to say that unfortunately, I think people with chronic pain are still stigmatised against. I think people still think that they're imagining it. It's all in their head. I have to say that one of the things that I was very, very cognisant of was legitimising my patients' pain and basically, telling them that I believe them. Unfortunately, there isn't a quick cure. There isn't a quick answer. Most people with chronic pain are going to have to learn to live with it. But people can very successfully. And one of the biggest examples I always talk about, or did talk about, with my patients was the Paralympics. Because so many of those athletes would have chronic pain, phantom pain, spinal cord injury pain. In fact, I used to say to my patients that many of these people have got pain, but they've been able to manage their pain themselves and lead very successful and great lives and can be very proud of their achievements. And you can do the same, but you need someone to help you and support you do that and not rely on medication because, of course, as we know currently, there is no drug that works well for chronic pain. Nothing does. My job was to legitimise the patient's pain, and I think I really tried to do that successfully from what patients said to me over time. Of course, I did have some patients angry with me because I was stopping their opioids, but even some of them came back later and said, "You were right. I feel so much better. My pain's no different, but I feel so much better in my brain."
What do you see as the big challenges for the future of pain medicine?
I think funding is a big thing. As we know, there is still long waiting lists to get into pain clinics. People can't afford to see psychologists privately. So what do people with chronic pain do? And what they do need initially is a good GP who is prepared to help and support them. I do believe they do need to be referred to a pain clinic, even if it is a long waiting list. At least get referred so that at some point of time you can get a consultation and get some advice and perhaps feed into that program if it's appropriate. Potentially in the longer term, community education would be a good thing. There are a number of very good websites that patients can be directed towards that actually teach people about chronic pain management, teach people about the risks of opioids and medications, and I think that they need to be publicised more. Somehow we're going to have to do better community management of chronic pain. You can get very good education through the community.
On another note, I understand that you have been a Justice of the Peace for about 20 years. Given that doctors are already qualified to sign and witness documents, what motivated you to take up that extra?
I must admit, once again, it was something I thought would be interesting. And early on, when I did it, I even wondered about volunteering in the courts. Because to a certain extent, I'm always about education, and so it was another qualification I had to do, and I had to sit another exam to become a Justice of the Peace. So I started doing it initially just because I thought it would be interesting. And then when I retired, I thought, well, what am I going to do? How am I going to give back to the community? And I suddenly thought, I'm a Justice of the Peace. So I rang the local council and, yes, we need you. So I now volunteer twice a week.
What does that involve?
Well, I basically go into the Henley Library one day and I go into the local council chambers on another day, and people come in and bring all their documents in, and it's very like being a doctor because they sit down, they come in with a problem, they say, this is what I need you to do, and you either say, yes, I can help you, or no, I can't help you, or you say, look, perhaps you need to do this instead. You're not meant to give advice, but you can sort of guide them. And then you sign their documents and send them on their way. So I just chat to people, and it's a really nice way to volunteer. I always figured out I'd be hopeless doing Meals on Wheels.
It's interesting that you mentioned Meals on Wheels, because I also heard that you like to host dinner parties.
I do.
So you like to cook?
I'm known for my green chicken curry.
Thank you very much for your time today.
Thank you.
And thank you for your expertise and wisdom throughout the years of the Faculty of Pain Medicine.
Thank you, Gretel. It's been lovely meeting you.